Good morning. Welcome to Savitha Dental College Lecturecast. Today's topic will be on maxillary osteotomies. Maxillary osteotomies are classified into segmental osteotomies, which consists of a single tooth osteotomy or corticotomy or anterior or posterior segmental osteotomies, and total maxillary osteotomy, which may either be a LEFORT 1, 2 or 3. The anterior maxillary osteotomy is indicated when there is an anterior open bite or when there is a bimaxillary protrusion or when there is a deep overbite. There are four commonly used techniques in doing an anterior maxillary osteotomy. They are the Wasserman, Cooper, Wanderer and Epker techniques. In the Wasserman technique, two vertical incisions are placed in the premolar region and along the frenum, and a midline sagittal incision along the hard palate. The osteotomy is carried out using these incisions and the maxilla is mobilized and fixed. In the Wanderer technique, it is almost similar to Wasserman except for the fact that the palate is exposed by a transverse palatal incision with the margins away from the osteotomy site. The Cooper technique is the most frequently used technique where the approach is via a short vestibular incision and all the bone cuts are performed from the labiobuccal side and the separation is completed by an osteotome and down fractured using finger pressure. The posterior maxillary osteotomy is indicated in correction of an anterior or posterior open bite and correction of posterior cross bites. There are two types, namely Schuckardt technique and the Perkobel technique. In Schuckart's technique, a vertical incision is given in the buccal region and it is combined with a parasagittal incision on the palatal region. The osteotomy is done using these incisions and the segment is mobilized and fixed as per the necessary movements. Perko and Bell used a horizontal incision on the buccal aspect and the osteotomy was made 5 mm above the apices of the molar teeth. The palatal osteotomy was performed through the buccal osteotomy and the segment was mobilized and fixed as per needed. The advantage of the Perkobel technique is that a palatal incision is not required to do the osteotomy. The LEFORT 1 osteotomy is the most versatile maxillary orthognathic procedure. It is indicated in cases of vertical maxillary excess, maxillary deficiency, open bite and bimaxillary protrusion. The osteotomy cuts follow the LEFORT 1 lines which was set forth by René LEFORT. The osteotomy cuts can also be modified as per the patient requirement. Once the osteotomy is done, the maxilla is down fractured by using a finger pressure. The pterygoid plates are fractured by using a pterygoid chisel. Once the osteotomy is performed, the segment can be brought forward, inferior, it can be rotated and it can also be taken superiorly. Once the required position is achieved, the segment is fixed by using mini plates. Additional procedures such as alar cinching and vivoplasty are done. Alar cinching prevents the alar flaring and a vivoplasty helps in lip lengthening. LEFORT 2 osteotomy is indicated in patients with a deficient zygoma with the nasomaxillary deficiency, and a LEFORT 3 osteotomy is indicated in patients with a severe form of craniofacial dysostosis like Appert's and Crouzon syndrome. Thank you.